they identified MR imaging, positive imaging, nearly 70%. So anyway, OCT and CMRI can identify 85% cause identified, right? So this is an algorithm how to treat a non-culprit vessel, right? After primary PCI, if you identify some disease non-culprit vessel, especially it is intermediate, we have to do the physiology first, and then if it is positive, we have to do the PCI at non-culprit lesion. We can obtain a good prognosis. If it is negative, we have to treat optimal medical therapy, and prognosis is acceptable. And if the non-culprit lesion is significant, anyway, we try to do the PCI. Using imaging, the result is very good. And even in case with an optimal medical therapy in non-culprit site, there are lack of evidence of how to identify the non-flow limiting vulnerable plaque, right? So, but I focus on the physiology-guided non-culprit lesion treatment. As you may know, if the physiology is positive, it is important to do the PCI even in non-culprit vessel to improve the prognosis. That is supported by the several studies as shown in this slide. And if the physiology is negative, the optimal medical therapy is ideal. However, by imaging, we do not have these recommendations, these algorithms at the moment. There are some recommendation. If the MLA is less than 4 square millimeter, it might be significant. However, it is not fixed yet. If the MLA is over 4 square millimeter, we can defer. But less than 4 square millimeter, we have to confirm by physiology. In left main stenosis, the MLA is more than 6 square millimeter, we can defer. But even if the less than 6 square millimeter, we have to confirm the ischemia by physiology. How about the OCT? Compared with physiology, the cutoff value of MLA is around 2 millimeter square, right? So we can use this cutoff value. But this is not an ACS non-culprit vessel study. It is a stable coronary artery disease study. But this is very interesting. They randomized FFR guide, physiology guide, and OCT guide. And FFR is less than 0.80. They did an PCI. And if the area stenosis is more than 75% or MLA is less than 2.5 or rupture, they decided to do the PCI based on OCT findings. If there are other findings, they did the optimal medical therapy. And if you do the OCT guide, the PCI number is increased, significantly increased compared with a physiology guide, and cost is a little bit higher, as shown in this slide. On the other hand, prognosis, OCT guide is significantly better compared with a physiology guide, and also TVF is very similar to the MACE, right? And the target vessel lesion revascularization and significant angina non-fatal MI is significantly higher in physiology guide compared with OCT guide, and primary endpoint is significantly different, and the OCT guide is better as shown in this slide. So this is the summary. If you do the physiology guide, medical therapy increased and kidney injury decreased and cost decreased. And if you do the imaging guide, especially OCT guide, number of PCI will increase and contrast medium use will increase. However, MACE or a significant angina decrease. There are some difference. So we can apply these conditions in a non-culprit vessel, I hope, right? Therefore, in case with a negative FFR, a negative physiology case, we selected the optimal medical therapy previously, but we have to decide the non-flow limiting vulnerable plaque. At that time, we can treat that lesion to improve the prognosis. How we can speculate the future event based on the plaque characteristics? There are several data, as we know, that are based on IVUS, NIRS, IVUS, and OCT, but all the data demonstrate high negative predictive value and low positive predictive value. But as you know, the invasive imaging technology may allow us to detection, allow us the detection and the management during the index procedure of multiple culprit lesion, often not easy appreciate by angiography alone. Okay. And so I would like to focus on the OCT. This is the data from my friend Italy, the CRIMA study. Inclusion criteria is, as shown in this slide, they focus on only LAD, and this is an exclusion criteria. And if the region MLA is less than 3.5 square millimeter, fibrous cap thickness is less than 75 micron, and lipid arc is more than 180 degree. The event rate is significantly high compared without these findings, as shown in this slide. But the predictive value is only 90% for 4 years, 2 years, I forgot. But that is very similar to the previous study, high negative predictive value and low positive predictive value of MACE. This is the 1 year clinical outcome. If they find such vulnerable condition, we can speculate a higher event rate, but the event rate is only 90%. Is it okay to put a stent that region? We have to anyway do the some yes prospective study. As shown in this slide, each yes index demonstrate high low sensitivity and low specificity, and negative predictive value is very high but low positive predictive value. We did a similar study. We followed nearly 1,400 patients, and the non-culprit plaque. We followed this non-culprit plaque, and this is the summary of the event and plaque condition. Lipid-rich plaque with thin cap fibroadenoma ACS occurs in the future, right? And the fibrous plaque and calcified plaque, there are no ACS as shown in this slide. And this is one of the example, right? The cap thickness is very thin, very lipid-rich plaque, more than 300 degree, and some macrophage accumulation. 10 months after, we can identify the rupture and coronary occlusion, demonstrating myocardial infarction. So the lipid-rich plaque demonstrate higher event rate TICFA also, and if there are lipid-rich plaque and TICFA, the event rate is significantly high. And also, if we identify the lipid-rich plaque more than 180 and TICFA less than 150 micron and MLA is less than 2.9, the event rate is 32%. So if we identify these findings in non-culprit region, we try
Dr.
to...
Akasaka.
Yes. I will finish.
Sorry to interrupt. Yeah, you have exceeded by 4 minutes. So if you kindly summarize and
okay, this is my take-home message.
Time bound, especially. Yeah. Thank you.
I'm sorry. Yeah, this is my take-home message.
No, thank you.
OCT may provide us precisely the region morphology of significant stenosis in non-culprit vessel, and it would be useful for PCI. There is no obvious OCT criteria of PCI indication for non-culprit lesion in ACS, although improvement of prognosis has been demonstrated in physiology-guided non-culprit lesion PCI using clear cutoff value. Compared with a chronic coronary syndrome, non-culprit lesion should be significantly high in ACS, although prediction of future event based on morphological characteristics by OCT or other imaging might not be enough high in various imaging modality. A prospective study should be done based on this background. Thank you very much for your kind attention.
Thank you, Dr. Akasaka, for your excellent speech. And really, it was a very fascinating one. And please, you wait with us and moderate the session and chair the session. And I will come back to you with all the chairpersons to have the discussion after 2 sessions, because many of our international faculties are time bound and they have
Okay.
got specific time. So kindly excuse me, I
No,
apologize.
no.
So
I'm
I
very
think,
much sorry. Yeah,
Doctor, no,
thank you
no,
very
thank
much.
you, sir. Thank you very
Thank
much,
you.
sir. And all our, faculties are very pleased to have your lecture from Japan. And thank you very much, sir. And I would invite Dr. Gary Minch, and I think he doesn't need any introduction. And Dr. Gary Minch is a legend so far as IVUS is concerned and as a whole regarding the cardiology arena. So I would greet Dr. Gary Minch, and if you kindly deliver
Okay, so I need Professor Akasaka to stop sharing his screen so that I
Okay.
can.
so
Wait a moment.
Dr.
Yes.
Saga,
Yep, excellent.
yeah, thank you very much. Thank you, sir.
Excellent. So you can see my slides, correct?
Yes, sir. Yes.
Not till now, yeah.
Okay. So I've been asked to talk about IVUS guidance for coronary vascularization, when we start and when we stop. Well, so when do we start? We start when there is a flow limiting or ischemia producing lesion that is amenable to stent implantation. Many randomized trials have established intracoronary physiology using either FFR or IFR as a technique of choice in deciding when you have a flow limiting or ischemia producing lesion. We have tried for decades to come up with equivalent imaging parameters. And as you can see, the MLA cutoff varies from 4 to 2 square millimeters. In general, the positive predictive value is about 50%, while the negative predictive value is much higher. We've also looked at lesion length and plaque burden, and they're not much better. And one study even looked at combining MLA with plaque burden, and it's not better. The main reason is because imaging cannot factor in the amount of viable myocardium that is supplied by the vessel with the lesion. This study from Korea shows that even a proximal LAD has a wide variation in the amount of viable myocardium. In terms of what would be a reasonable cutoff factory in all these studies, well, at least in the West, it's probably about 3 square millimeters, as shown by these two meta-analyses. Therefore, while in some cases it may be reasonable to defer PCI based upon a large IVUS MLA as suggested by Professor Akasaka, it is never appropriate to justify performing a PCI based on a small IVUS